that is hormonal therapy, reset, timing, safety, and individualization. And our moderators are Dr. Sheila Mane and Dr. Nija Agrawal. The panel experts is Dr. Chandrasekhar sir. The panelists are Dr. Sheila Jain, Dr. Kanchan Sorte, Dr. Rashmi Budia, Dr. Anchal Agrawal, Dr. Jyotsna Gupta, Dr. Chetna Ramnani, Dr. Suma Ekka, Dr. Pratibha Tiwari, Dr. Sarika Sahu, Dr. Dhruba Ray, and Dr. Neeraj Pehlajani.
Yeah, just show them. Bas.
I think we need one more chair. Excuse me.
2 more chairs.
Volunteers.
2 more chairs.
यहाँ पर आ सकती है. Chairs यहाँ पर डालिए. We need 2 more
2 more chairs.
Up either. Don't fall there, otherwise there is hardly any space. यहाँ रख दीजिए.
थोड़ा सा इसको ऐसे कर दीजिए टेबल को. 1 more chair.
स्क्रीन नहीं दिखेगा ना उनको. हाँ, इसको ऐसा रखो. जाओ.
पढ़
go,
पाएंगे.
go.
1 more chair.
So a quick round of introduction, your names.
Yes, yes. So we start the panel on hormone replacement therapy. So welcome everyone on the first panel. Dr. Sheila Mane, Madam is a Joint Treasurer of Indian Menopausal Society, and she is also ICOG Chair for 2026. I am happy to share the stage with her. Myself, Dr. Neerja Agrawal. I have with me panelist Dr. Anchal. She is a consultant at Shubh Hospital.
May I know who is Anchal? Yeah. Then
So just say hello to everyone. Chetna, she is a Ramakrishna Hospital consultant. She is Dr. Chetna. Then Dr. Jyotsna, she's here? No. Dr. Kanchan, welcome madam from Soti Clinics, Nagpur. Pratibha is a IVF specialist. Dr. Suma, she is assistant professor at PTJNM Raipur. Dr. Sheila, welcome madam, she is from Nagpur. And Dr. Sarika, she is a consultant at Prithmesh Hospital, Raipur. So let us start straight away with the panel.
Yeah. So we have 4 cases to discuss, and all of us we know about the definition, so I will not go into details. So the patient is postmenopausal, 2 years ago, LMP, severe vasomotor symptoms, hot flashes, night sweats, BMI is 29, and she is hypertensive on treatment. So her chief complaints are severe hot flashes, 8 to 12 episodes per day, and drenching night sweats, menopause, postmenopausal. She is at average age she had, that is 47. Medical history, she is known hypertensive, and BP is controlled currently. BMI is 29. And as according to Asian overweight threshold, definitely she is overweight. And that could lead to some complications like VT, and so route selection is a most important thing. Uterus is intact, and there is no personal or family history of breast cancer or VTE. Next. So, Anchal, how does this differ from the global average, and how will you do the step-by-step clinical assessment?
For Indian women, average age of menopause is around 46 to 47 years of age. And
Yeah.
globally, according to WHO, it is around,
Closer.
globally, according to WHO, it is around 51 years of age group. So she perfectly fits according to Indian women's age groups. She is 47 at 47 years of age. She has attained her menopause. So she is having all VMS symptoms, which is moderate category for her. She also has controlled hypertension.
Hmm.
So,
So how do you,
initially,
assessment now?
history first, I'll ask her basic history. So whether she is taking her antihypertensive drugs or not. And secondly, I will assess her VMS symptoms, which is according to green climatic scale.
Hmm.
So whether it falls under moderate, mild, or severe category. And then her menstrual history, previous menstrual history, how were her cycles from exactly from 2 years, she's menopause or not, whether she has not attained, she did not have any.
She's already,
menstrual symptoms. Yes.
yeah.
Then
Any
her
investigations you would like to do?
Ma'am, investigations per se, FSH is not required because
Not
according
required.
to
I don't
Swan
think it is
study,
required. Yeah.
menopausal
Yeah.
symptoms are sufficient to diagnose. Then to start, like in my mind already, I have to start her on MHT because she has VMS symptoms, which falls under moderate category because she has severe symptoms. Then she also has controlled hypertension.
So just mention
Start
the
on-
investigations, please.
Yes, ma'am.
Investigations you focus on.
Just mention that so that we can move.
Basic CBC, FP, for
See, now
rule
she
of
already
metabolic
has
syndrome.
hypertension. So she is prone for NCD.
Yes.
So we will also have to, hyperglycemia also we need to
metabolic
investigate her.
syndrome rule out, FBS, HbA1c, lipid profile.
And,
Then
yeah.
LFT,
So
RFT
now
and
if
PAP.
we come to examination and risk stratification in that also, these things are important.
Yes, ma'am.
Yeah.
Yes, ma'am.
So she falls under the window of opportunity.
Yes.
Yeah.
Okay.
Okay. And risk stratification, you know now as she is hypertensive, there is a VTA risk. Okay. Yeah. And we have to see whether the hypertension is controlled. So the next question goes to Dr. Josna. What are
Dr.
All-
Jyotsna is not here, ma'am. Anyone can take.
for hot flushes in this patient?
What are the treatment options for hot flushes in this patient? Anyone can take.
MHT is the gold standard for hot flushes are concerned. And since she has the history of VTE, we have to change the route. Like transdermal would be better in this case. That is one thing. If she cannot tolerate MHT, then other options are there like SSRIs, paroxetine. We have been using it very regularly. That is the
So
thing.
according to you, only transdermal or we can still try oral in
We
her
can
case?
try.
Her
but
blood
there
pressure is under control.
Yeah.
Yeah.
Yeah, it is under control. We can try, but the ideal would be transdermal. in
Means
this,
you'll have to do the risk assessment and explain her the risk.
this.
As she is already having hypertension, but it is not that it is not to be given. We can still give. Okay.
Yes.
Yeah.
Yes. Tibelon is another option we can consider.
And another option, suppose if she is not able to tolerate
Yeah, I
or
told
if,
SSRIs, paroxetine, gabapentin, we can consider.
and lifestyle is there for
Always,
everybody. I think
always.
it is complementary, which we will have to. And as the uterus is intact, I think we'll have to add
Progesterone.
progesterone also. So what are the types now? Again, it was
Yeah,
your
there are
question only.
basically two types. One is sequential and another is continuous combined therapy. These are the basic two. Then whether uterus is present or absent, it depends on that. If the uterus is present in sequential therapy, you have to give estrogen every day with progesterone lasts 12 to 14 days. And if uterus is absent, continuous estrogen only if the uterus is absent. But in certain special situations like previous history of endometriosis or endometrial ablation or subtotal hysterectomy, you have to add progesterone even if the uterus is absent. That is, these are basic two routes of this thing.
What do you think about Tibolon?
Yes, Tibelon postmenopausally after 12 months of amenorrhea, you can give Tibelon daily.
Any particular symptom you think that you will prefer Tibolon?
Mood swings, hot flushes.
No,
vasomotor
hot
symptoms.
flushes we are using, but
Yes.
any other, the patient has any
Loss
other
of
symptom?
libido.
Yeah, I
loss of
think,
libido.
okay.
Yes.
And physical exhaustion particularly, the Tibolon will be better.
Yes.
So the route of delivery, as you already mentioned,
oral
okay.
and transfer.
Yeah, liver bypass will be there. We can use, but we can use even the oral also, but you will have to monitor.
Yes.
And whether sequential or continuous,
Yes.
you already mentioned about that. Okay. Yeah. LNG IUS also plays a role. If you don't want to give, you can just give and use that also. So what is the complex management plan for her now?
Anyone can answer?
Complete, sorry.
Dr. Neeraj is not here. Anyone can answer? So what is the
Yeah.
complete plan?
After taking complete history, we know that the management is definitely MHT. So we have to take complete history and rule out what can be the contraindications for starting MHT. After that, we have to start her MHT. In this particular patient, since the weight is more, BMI is more, so the preferable choice would be transdermal route. But as madam said that she's also hypertensive, but BP is well controlled. So we can give her option of transdermal as well as oral.
Oral, how much dose you would like to give?
Uh,
And which
Yeah.
combination you would like to use?
Either micronized progesterone or dydrogesterone are
And,
preferable.
And estrogen, which estrogen?
Uh, estradiol,
17 beta,
17, yeah.
beta estradiol. So you get 2 mg, you get even 1 mg also
Yes.
now. You get 1 by 5, 1 by 10, 2 by 5. So different combinations are available. Okay. Lifestyle, as we said, is very important. Weight management and all that, and calcium and all that. The other things also like reduce alcohol. What about the monitoring now?
We
How
have
will you
to-
monitor her after you have started?
Once we start the treatment, we have to follow her up after 3 months. In that period, we have to ask about the compliance of the drug, any side effects with the drugs, and then if it is okay, then we'll follow her up at 12 months. And again, we have to see for compliance, side
But she is
effects or other
hypertensive.
effects.
Do you think we would like to review first 3 months? I mean, early. 12 months will be too long.
Yes,
It's better
yes.
we call her after 3 months and then reassess her. Okay?
And then annually we have to examine her. Apart from that, we also have to examine her breast, and certain symptoms may be associated like withdrawal, bleeding in between she is having bleeding or other complaints which we have to take care of.
So, how would you manage this patient if she had no uterus, Dr. Pratibha?
Madam, if this patient had no uterus, we can avoid progesterone in this patient. And for estrogen, we can give transdermal estrogen or estradiol 2 milligram per day or conjugated equine estrogen.
I think that was our age-old drug which we had.
Yes,
So, we can use CE also. Okay.
Tibolone is also one option. And only in the case if the patient has endometriosis, we can consider adding progesterone in this patient.
Yeah, which Dr. Kanchan already mentioned about it. So, we can just give her estrogen. Okay. Which one is better, you think? 17 beta estradiol or equine estrogen? She's hypertensive.
Madam, in this patient, I think transdermal is the best.
Best.
And then estradiol 2 milligram per
Yeah,
day.
I think
Because
oral
it is
17 beta estradiol is
bioidentical
a
hormone.
biologically also, and all other, the effect on lipid profile and everything
Favorable.
comparatively better with estradiol than with conjugated equine estrogen. Yes. So, what are the absolute contraindications?
So we have to find out whether there is any current, especially for estrogen dependent tumors, breast cancer, whether she's already a case of current breast cancer or she herself had any past history of breast cancer, and for that matter, family history also. And same thing with endometrial cancer, because these two cancers are estrogen dependent. So naturally, there will be little hesitation, and basically it is absolutely contraindicated. She has, if she says that she has some unexplained vaginal or uterine bleeding, so without diagnosing that, without finding out
Yeah.
the reason for that, then any endometrial hyperplasia, and whether she is, because she is little obese, so what is her cardiovascular status, and whether she had any time history of venous or
Yeah.
arterial
Even
thromboembolism
that,
in
then
the
liver
past or
disease,
present,
Yeah.
and whether in Indian setting where all these thrombophilias are not very common, but then still we have to find out about all
Relative
these.
contraindications?
I mean, because if she is very obese, I mean, more than
These are all
30, if she is,
relative. Yeah.
and as everyone is telling that endometriosis, definitely, I mean, we should be avoiding that. And if personal or past history of breast cancer, but these estrogen dependent tumors, in case there are family history, then you can still, consider
With caution.
giving. And any other neurological like epilepsy, liver disease, active liver disease or gallbladder
These
disease,
will be the relative.
migraine.
So, I think
that
complete, as Archana mentioned, I think complete history taking makes very important because we will have to know all these things. Yeah. Next. So, what is the risk of breast cancer?
Such risk of breast cancer is not very high with actually the progesterone component constitutes.
Can you come
Increase
closer
risk.
to the mic?
Switch on the mic.
It's switched
Yeah.
on. Am I
Yeah.
audible now? So it's actually the progesterone component which may slightly increase the risk of breast cancer. And this is minimized if she uses micronized progesterone.
Or dydrogesterone?
What we need is a very good, like we said, history taking and a very good counseling that we need not frighten her away. We just have to tell her that if at all there is increased risk, we have to tell in case of numbers. Only 1 per 1,000 increased number of
Women per
breast
year.
for
Yeah,
1,000
that is
women who
there.
are using it. If she uses, say, medroxyprogesterone, then also it's just 1 to 2%, 1 to 2 extra cases per 1,000 women. Rather, the increased risk is much more because of her lifestyle.
Yeah, per se now it
Yeah.
is the first cancer in women in India. Cancer cervix has taken backstage and cancer, breast cancer. So evaluation becomes very important
Very important.
for every woman.
And then
Yeah,
we should counsel her about a very regular
Yeah.
follow-up.
next. Yeah. So how long should MHT be continued and when should it be stopped?
As such, there is no endpoint as to how long we have to start MHT. Basic crux is that we have to follow up the patient. We have to see how is her compliance, what are the side effects, and accordingly we have to decide whether we have to continue it or not. So we have to give treatment, keep in follow up, and then ask her to continue for some time. Again, follow up, see what are the complications, and again continue. So as such, there is no cutoff point.
Actually, to be very frank, when we are talking, I mean, NICE guidelines is 5 years, but we don't find anybody in our country in continuing so much, okay? So first we have to see that they settle with their symptoms because they will be suffering with vasomotor symptoms so much. So 3 to 6 months, happily they will take. Then after that, it becomes, I think, your counseling. In POI cases, I think she will come to that, the next case. So I won't go into detail. So, and when and how to stop, that is important.
Should not stop it abruptly because if we stop it abruptly, the symptoms may exaggerate. So we have to slowly taper the dose for over a period of 3 months and then we have to stop.
Yeah, that is important. I think all seniors sitting here will agree that earlier Tibolon was very popular and patients were so much used to that they wouldn't stop it because stopping would again give them symptoms. So it's very important to counsel them because they feel very comfortable with Tibolon. Yeah. I think she needs a mic or anything. You wanted to comment?
Please provide a mic.
Non-breast
They-
cancer risk and how are they managed? Next, Dr. Sarika.
There is increased risk of venous thromboembolism with the oral estrogen. This can be reduced by using the transdermal route. And there is increased risk of ischemic strokes also with the oral estrogen. And transdermal route has no risk. And with endometrial hyperplasia and endometrial cancer risk is also increased with estrogen. So that we can add progesterone.
We always add progesterone, intact uterus.
Intact uterus.
Ovarian cancer, as such, very small
Very
increase.
small risk.
Okay. Absolute risk does not change. Gallbladder, we discussed. Cognition and dementia. Window period of opportunity. Maybe neuroprotective.
It is
Okay. But it has not proven that for that reason we have to give. As well as even the CHD also. I mean, CVD also, it gives them some protection. As well as bone and osteoporosis if it is used in the window period. Yes. Next. I think
So
you can take
there
over.
is an announcement from organizing that they are closing the breakfast. So anyone who has arrived in late may take it so that the breakfast might be closed and start for lunch. We come to the next case scenario. She is 54 years female, having from the past 3 weeks an unscheduled light bleeding. She has attained menopause at the age of 51 and she has been started 8 months back with a continuous combined HRT, which consisted of estradiol gel 1.5 milligram and micronized progesterone 100 milligram daily. Now she has no history of heavy periods, but she has diabetes